you all for joining us for a Q&A session here with the Bateman Horn Center. And our hope today is that by giving a little presentation covering a couple different comorbidities, it might touch on some of the questions that you're having. In no way are we saying that you have any of these comorbidities, but if these are things that you feel you might relate to, we're going to give you some tools to go back to your physician and hopefully have a deeper conversation with them. I'm going to turn the floor over to Dr. Bateman.
Okay, thank you very much. Can you hear me okay? All right. I wanted to start by sharing with you the experience we've had of enrolling and partially evaluating patients sort of on a select basis through the Facebook group, the Long Haulers Utah Facebook group. And so we after the first 24 people filled out the application online recently, we decided we'd compile a little bit of the data and share it with you. So there are 24 patients that we're going to be talking about in these next couple of slides. 23 are female and 1 is male. We ask a number of questions that the World Health Organization is asking researchers to query in long COVID. Those were if you worked in healthcare or in a lab when you got your COVID. And of course, the majority of ours at this point, 84%, did not. We asked if the applicant had been diagnosed by a health provider during their acute COVID-19, and it was split. About 58% had, and 42% had not been diagnosed by a healthcare provider. But of those who were diagnosed by a healthcare provider, 11 out of the 14 had a positive test, some kind of an objective test of their COVID. And of those 10 who said they weren't diagnosed by a healthcare provider, only 2 had a positive test. And you can think about the ramifications for that. Doctors may be hesitant to make the diagnosis if you don't have a positive test. And the majority of our patients have not been vaccinated yet. Oh, the other part of that slide, as you can see, we're trying to see a set of people who were not admitted to the hospital and are mostly patients who manage their disease outside of the hospital and those who'd been sick at least 12 weeks. The reason for this at BHC, there are many. One is that we were really trying to study post-viral syndromes that might be similar to ME/CFS, and there are a lot of compounding organ damage and other things once people are sick enough to be admitted to the hospital. And we're a general internal medicine type clinic, not a specialty clinic. So duration of symptoms, everybody who signed up felt like they were still having symptoms from COVID-19. The majority of them had been sick more than 6 months, and then right behind that, 3 to 6 months since they had their acute COVID. Now, this is interesting because we ask the questions in a way that we can tell in the screening process if these patients appear to meet criteria for ME/CFS. So let me tell you a little bit about that. These are the major criteria for myalgic encephalomyelitis chronic fatigue syndrome. The first criteria is impairment of function in association with fatigue. We broke those apart here. And you can see that 89% of our patients felt they had impairment of function. The second is post-exertional malaise or relapse of illness after doing activity. That can be cognitive or upright or physical activity or even emotional stress. And you can see that was actually one of the highest endorsed by our long COVID patients, and unrefreshing sleep, and then either cognitive impairment or orthostatic intolerance. And in order to meet criteria for ME/CFS, you need to have these core symptoms, one of these or both. Your symptoms have to be present more than 6 months and be present at least 50% of the time, and moderate to severe. So you can see here, well, 53% without a physical and a real history, but filling out surveys, 53% met the Institute of Medicine criteria for ME/CFS of our long COVID applicants. And these are other common symptoms that occur in ME/CFS: widespread pain, headache, POTS, allergies, and sensory. So you can see that we're looking at patients who've been sick quite a long time, and at least half of them meet the ME/CFS criteria. I would like to say here that when most of the ME/CFS research is done on patients who've been sick many, many, many years. So remember that if you have long COVID and you meet criteria for ME/CFS, you have a very good chance of recovering or improving in that time window, because we really don't know how many people recover in the first few years of ME/CFS. We have a lot to learn about that, and that's why it's so valuable to be able to study long COVID and understand more about post-viral syndromes. So other long COVID symptoms, we compiled a list of typical symptoms of long COVID that were in the Body Politics study and other papers that have been published on lingering symptoms of acute COVID-19. I've highlighted the ones, bolded the ones that are more than 80% in more than 80% of our patients. And you can see sleepiness, palpitations, weakness, muscle pain, joint pain, stomach ache, and many, many others. And I think in a way it's notable that cough, wheezing, painful breathing are getting less and less common, although many patients are short of breath. And I'll just say that can relate to what's going on with orthostatic intolerance and POTS in many patients. Also, a pretty high comorbidity of anxiety and depression, which is very understandable, not only from the situational standpoint, but because of what we think is going on in the brain with this post-viral syndrome. Now I'm going to turn the time over to Dr. Yellman to talk about, we're going to talk about some of the major manifestations, and especially those that might not be easy to understand until you've experienced something like this.
Thank you, Dr. Bateman. So I'm going to start by talking about this concept of post-exertional malaise, or what we call PEM. And the reason we're starting here is because it is such an important feature of the post-viral illnesses we've taken care of up to this point. And many of those we've talked to with post-COVID are experiencing symptoms that appear to be similar, if not directly, a manifestation of post-exertional malaise. So what is it? We know that people coming to us have an overall function that is impaired every single day compared to how they used to be pre-illness. But among that impairment, there are good days where people are less impaired, and then there are bad days where their function is more severely impaired, even compared to their now reduced baseline. And it's these bad days that are representative of post-exertional malaise, which is really a physiological state. And in this physiological state, we know that generation of energy at the level of cells is severely impaired, even compared to at your baseline. And so it's no wonder that people feel worse and function worse with that underlying pathophysiology. Post-exertional malaise is brought on by exceeding a limited store of available energy for bodily function. And that is by utilizing a lot of energy in a very short period of time. So for example, you could do way too much on one day, or alternatively, you could do just a tiny bit too much many, many days in a row, and then all of a sudden it catches up with you after 2 weeks. So both can trigger post-exertional malaise. And these energy expenditures that we're referring to need not be going on the treadmill and running. They need not even be physical activity, but they can also include cognitive activities. And cognitive can mean, thinking activities, reading, doing math problems, trying to comprehend things, but it can also include social activities, processing of information, being in a crowded restaurant. Not too many of us are there right now with COVID, but processing a lot of sensory input all at once is a cognitively demanding task as far as how much energy is required to do it, whether or not you do that consciously or subconsciously. And then even emotions require a lot of energy. So that can be good emotions or bad emotions. Next slide, please. So when we talk about post-exertional malaise, we want to recommend to everybody in this, especially in this initial period of illness, to prioritize avoidance of these crashes or these episodes of post-exertional malaise. And we think that's really critical to having a good functional outcome in the long term. What we do know about post-exertional malaise and other post-viral syndromes is that these crashes are actually representative of neuroinflammation and what we call neuroinflammatory injury. They can stack upon one another when you put them close together in succession, and you have to think of them as an injury. You don't want to re-injure something that is already still healing, or it's never going to heal. We know from other post-viral syndromes that repeated crashes over time are associated with a worsened functional prognosis, and that people lose more and more function if they continue to push past their energy limits and into this physiological state. And so one way to think of it is almost a neuroinflammatory scar. It's not a clear connective tissue scar, but changes in the way the brain and the subsequent signaling pathways function that may or may not be reversible in the long term. We also know that once you are in a crash of post-exertional malaise, there's really not all that much to do other than to limit your energy as much as possible so that you can recover from that crash and not make it worse. If you continue to try to expend energy and push to the ends of a very reduced energy envelope in post-exertional malaise, it tends to only prolong that crash. We also get calls from patients all the time, hey, I'm in a crash, what do I do now? And while there are one or two things we can do to help on a very small level, the general concept is really there's not much we can do to speed up recovery other than to say, sit back, almost surrender to it a little bit so you can get out of it quicker and avoid it moving forward. So the opposite of having crashes of post-exertional malaise is the concept of pacing and thinking about not exceeding the amount of energy you have available, which is much easier said than done, but it is indeed the most critical component of managing this whole constellation of symptoms. And it's more important than anything any physician can do for you. If you cannot avoid post-exertional malaise and eventually maintain some pacing, it's really hard, even with good physicians, to make significant progress in your symptoms. So please do not underestimate how important this is in your overall recovery. So we like to say, try to remain within what's called an energy envelope in the post-viral community, or remain within your battery. So I used to have a Galaxy S6 that I would show people, and you could actually watch its battery decline in front of your eyes. And I say that that's sort of what it's like to have that kind of battery when you're dealing with a post-viral syndrome or with any CFS. And so what we want to do is modify activities so that you spend less energy for the same exact activity, if at all possible. So for example, if you are preparing dinner and you're chopping vegetables, could you do that sitting down rather than standing up and using less energy? Could you take a shower on a shower chair? And you don't have to pick, grandma's shower chair. You can pick a nice Japanese teak shower chair, but sitting can make it a lot easier to tolerate activities such as that. Even folding laundry, you can save quite a bit of energy sitting rather than standing. And if you can do activities like we're all working, many of us are working from home these days. If you work on a laptop or a computer, you can elevate your legs rather than having them hang below you in a more upright position. And that can make an enormous difference over time in how you feel and how you function. It's important to think about frequent rest and relaxation between activities. So take breaks, take more frequent breaks. Think about your day's activities carefully. Plan them out ahead of time rather than letting the day happen to you. Tends to be a more successful strategy. Setting timers for activities can be really important. I recall one of the very first patients I ever saw with a post-viral illness told me at one point she became despondent because she couldn't even do her hobby of painting without experiencing post-exertional malaise. She later came to discover that if she set a timer for 1.5 hours instead of going for a 4-hour marathon, she could wake up the next day and not be in post-exertional malaise. And then she expanded her energy envelope to the point where she can work on painting for 1.5 hours in the morning, take a break, do some of the recovery things that have worked for her, and then go back to painting in the evening for another hour. So no more 4-hour marathons, but she can still get quite a bit of painting in now. And setting a timer has been a good tool for her with that. It's also important to challenge your assumptions about what is an important use of your energy. You know, is it worth using all your energy to go to the grocery store, or might you be willing to spend a little more to have a grocery delivery service come and do that for you? If you are lucky enough to be able to afford a home cleaning service, maybe that will allow you to use that energy for something more important, like spending time with your kids or family or friends. So you really do have to think about, how do I want to utilize the energy I have so that I don't exceed that and go into post-exertional malaise? And what is the cost of doing any activity that I do? And then it can be really helpful to set voice reminders and lists on your phone. I know one example I heard from people a lot was, I'll go upstairs and then I get a little lightheaded and dizzy and short of breath. And by the time I recover, I forgot what I went upstairs for. And then I end up making multiple trips up and down the stairs that day. Well, before you go upstairs, say, I have to do A, B, and C. Get up to the top of the stairs, rest, recover, and then listen to your message. That can be really helpful. And these things really do add up over time. So this is shifting gears a little bit from pacing and post-exertional malaise. There are many people with post-viral syndromes who experience what we call orthostatic intolerance. And I wanted to just give a brief introduction as to what we mean by that, and how we see it maybe a little differently than the rest of the medical community. So by definition, orthostatic intolerance very simply is saying that a person is having difficulty maintaining an upright position as compared to a reclined position or a laying down position. And we would even go so far as to say feet on the floor is considered upright, whereas elevated legs or being back in a recliner or laying down is more of a non-upright position. And in particular, when people transition from laying down to sitting or standing, it's important to remember that gravity still plays a role, and it's exerting a force that pulls blood flow from your brain down back into the rest of your body. So healthy people in this circumstance are able to adapt to the force of gravity and maintain blood flow to their brain by activating what's called the autonomic nervous system. And this is a bunch of subconscious nervous signals that detect changes in position, and they send other neurological signals all around the body that help the body maintain a similar amount of blood flow into the brain when upright. And that includes constriction of the blood vessels that flow into the brain. In dysautonomia, or misbehavior of the autonomic nervous system, however, these initial adaptive features of the autonomic nervous system are inadequate to maintain enough blood flow to the brain to function optimally. They're not responding exactly as they should, and blood flow to the brain suffers. So there's actually a pretty recent ultrasound study, or what we call a Doppler ultrasound study, that measured overall blood volume going in and out of the brain on what's called a tilt table, which is really just assessing the difference between a reclined and an upright position. And very interestingly, healthy individuals who have a normal functioning autonomic nervous system display about a 6% decrease in blood volume to the brain when they're upright as compared to a reclined position. But that doesn't really seem to be enough to affect their functioning. However, people who had notable autonomic nervous system dysfunction would experience somewhere between a 24 and a 26% decrease in blood volume within the brain when they are tilted from a reclined to an upright position. So you can imagine with that, not only are you getting decreased blood flow in the brain, but if the autonomic nervous system is not working in other places in the body, other organs can be affected too. And so this is why people who have orthostatic intolerance or dysautonomia tend to recognize that upright positioning can worsen all kinds of symptoms, including things like lightheadedness and dizziness, heart palpitations or flutters, brain fog, muscle pain or aching, cognitive attention or focus, gastrointestinal function, headaches, and even shortness of breath, among other symptoms as well. And the majority of these symptoms are thought to be directly or at least secondarily and indirectly related to maladaptive blood flow responses during upright positioning, where you have inadequate functioning of the autonomic nervous system. So what is POTS, or postural orthostatic tachycardia syndrome? How does that fit in with this term orthostatic intolerance? How does it fit in with dysautonomia? So Many times in the medical community, we refer to POTS as a disease or a syndrome, but it's actually probably better defined as a measurable adaptive response to being upright. And this is an adaptive response that occurs when the initial functions of the autonomic nervous system are failing to maintain adequate blood flow to the brain or to other organs. So in POTS specifically, the adaptive response that we're measuring here is a rapid increase in heart rate when people move from a recline to an upright position. And this is actually, this happens in the body to maintain what's called cardiac output, or how much blood flow is coming out of the heart. And it's an attempt to increase cardiac output so that you get more blood flow back to the brain where it's needed when those initial functions of the autonomic system are not working. So in this case, the increase in heart rate, while it actually can make you feel worse or be associated with feeling bad, is actually not the pathology itself, but it's a response. It's an adaptive response to the underlying pathology, which is really the dysfunction of your autonomic nervous system in this case. So people with dysautonomia often experience another adaptive response to upright positioning as well. And we call that narrowing of the pulse pressure. And so that is a narrowing of the numbers on a blood pressure reading between the systolic, or the bigger number, and the diastolic, or the bottom number. And so while a normal blood pressure might be 120/80, as people go upright, they may find that their blood pressure becomes 120/100. And you can see how that is getting more narrow. And that appears to be a blood vessel mediated response that is also designed to maintain as much blood flow to the brain and important vital organs as is possible. So it's something we look for on some of our orthostatic testing measures, including something called the NASA lean test, which I won't touch on today. Dysautonomia as a whole is a very broad term, though, and it refers to dysfunction of the autonomic or automatic functioning of the nervous system in response to changes in the environment. And so it's not limited only to our discussion of blood flow thus far, but it can also involve other autonomic processes, which include control of digestion and what we call peristalsis, or movement of food and other items through the gut. It can also be implicated in creating imbalances between the sympathetic nervous system, commonly referred to as the fight or flight nervous system, and the parasympathetic nervous system, or the rest and digest nervous system. And actually what we often see is an inappropriate overstimulation of fight or flight responses in the body, even as the body becomes more exhausted and tired, and perhaps as a result of being more exhausted and tired and closer to the edge of that energy envelope. Dysautonomia has also been observed to create what is called arteriovenous, or AV shunting, and that can occur in all kinds of cellular tissues, including muscle, gastrointestinal tissue, and nervous tissues. And what's really happening here is blood is passed directly from arteries to veins, but it skips capillaries. And that's a problem, because capillaries are where we have a healthy exchange of oxygen, nutrients, and then removal of cellular waste products that then go back into the venous system. So when you skip that, you can understand that cells are not going to function as well in these various tissue beds.
So we're going to change the baton for a few minutes. And I'd like to say, before I talk about small fiber neuropathy, just want to make a few statements about orthostatic intolerance. And that is, there are many, many causes of orthostatic intolerance. Just a normal person who becomes dehydrated can have orthostatic intolerance. And you can get worse orthostatic intolerance if you lie in the bed all the time and never get up. So people who've been in bed, they've been sick and start to get up, they might, the room might, they feel like they're going to black out. And one of the causes is small fiber neuropathy, among others, including other kinds of autoimmune diseases where the antibodies actually attack the receptors on the nerves and in the blood vessels. But I'm sure you've heard a little bit about small fiber neuropathy. So I wanted to take a few slides and explain a little bit more about it, how it could affect someone after they have a virus. It can also be caused by many other things, the small fiber neuropathy, but we're in this setting, we think it's probably related either to the virus itself or to the immune response, this kind of vigorous, ongoing maybe dysfunctional immune response going on in long COVID. So small nerve fibers, we used to call them in medicine C fibers. They're like really tiny, hair-like, bare, meaning they don't have that myelin or the insulin around them. I'm sorry, the insulation around them that some of the larger nerves have. And these C fibers tend to be in two major parts of the body. One is sensory nerves, and that means they detect and transmit sensations, not just pain, but heat and pressure, cold and hot, and other kinds of sensations, not only from the skin, but there are a few other places in your body that have sensation, maybe a little different than your skin. And these small fibers are also the very end tip of the autonomic nervous system. These are really tiny nerves that go to what we call involuntary muscles. So the muscles in your arm or your legs are called voluntary or skeletal muscles, but you have what we call smooth muscle in your body. And these are in the wall of blood vessels and in the wall of your intestines, and then it can make up the outside of your bladder. And the autonomic nervous system controls the constriction and dilation, contraction and relaxation of these parts of your body that we call involuntary. So anything you can choose to contract is a skeletal muscle, and the rest are either smooth muscle, with the exception of your heart, which has its own kind of muscle that can spontaneously beat. So if you get a small fiber neuropathy, and neuropathy means it is a disease or damage to these tiny nerves that are kind of vulnerable, the pain symptoms you might get from a small fiber neuropathy could be cold-like pain or tingling or pins and needles, burning, transient electric shock pain, and it can occur in various places because small fiber neuropathy isn't limited to, say, your feet and your hands, like what we often call a peripheral neuropathy. And we've had lots of reports of these kinds of pain symptoms in our long COVID patients. And another typical kind of telltale sign of neuropathic pain is sometimes it gets worse when you're quiet or resting or trying to sleep. And it may be worse, and it may be that it's just harder to distract yourself when you're trying to go to sleep. So small fiber neuropathy not only causes those sensory problems, and I only talked about pain, but we know there are many other kinds of sensory problems that happen in long COVID and in other post-viral syndromes. But the autonomic dysfunction can really make symptoms all over your body. Dry eyes and dry mouth, the postural orthostatic intolerance, like Dr. Yellman's been talking about, abnormal sweating, all these GI symptoms, and then function of your bladder might be abnormal. So sometimes it's difficult to relate these to each other, but it's really can be one kind of systemic process that is affecting you all over your body and creating strange symptoms that can actually come and go. And if you think about what we were talking about, blood flow, if you've got a damaged nerve, these tiny nerves in your gut or in your bladder or in your skin, and then you deprive it of blood flow, good blood flow and oxygenation, that might be why the pain comes and goes, and sometimes it's worse and sometimes it's better. So the hard thing about small fiber neuropathies is they're hard to see. So you might even see a specialist like a neurologist, and they'll do a physical exam, a standard neurologic exam, and they might not pick up any evidence of a small fiber neuropathy. If they're really careful, and if they can sometimes, and they're really paying attention, sometimes you can find a little difference in the way pinprick effects or vibratory sense. But sometimes we're just moving kind of quickly through those exams, and you might have an exam that says you're fine, there's no reason to worry about it like a neuropathy. We also know that EMGs, which is electromyograms, and nerve conduction tests, really test the larger nerves. So you might even go and get these tests, and you could still have normal tests when you have a small fiber neuropathy. So this is just a picture from a publication of biopsies in a fibromyalgia study by Ann Louise Oaklander at Harvard. And in her paper, she said that skin biopsy is really the gold standard for diagnosing a small fiber neuropathy. Well, if you think about it, that's a little bit inconvenient. So you not only need to have, someone numb you up and take a little biopsy, but it has to be done carefully. And it really needs to go to a high quality lab with appropriate expertise. And if you are sloppy when you collect that biopsy and kind of, squish it or crush it or cut it, then the findings might be difficult to interpret. So the findings on, as you can see on the left, you can see these little teeny squiggly lines coming up toward the surface of the skin. Those are the small nerve fibers. And this one's normal and this one's abnormal. There's only one little teeny nerve fiber on this section of a biopsy. So it's frustrating, but I don't always get a biopsy in patients when I suspect they have small fiber neuropathy, because I can usually tell from exam that it's highly likely. On the other hand, if you want to get a clean and pure diagnosis, and particularly if you may become eligible for treatments for the consequences of small fiber neuropathy, then it's good to get a biopsy if possible. Now I'm going to turn it back to Dr. Yellman to talk about mast cell activation.
Mast cell activation is another concept we see in a lot of post-viral syndromes that we believe we might be seeing as well in the post-COVID community. And there's the term mast cell activation syndrome, which I think sometimes poses the idea that this is you either have it or you don't. But I like to think of this a little bit more as mast cell hypersensitivity. And it seems to be that people often fall somewhere, not always, but sometimes on a spectrum. So some people have it really bad, some people have it mild or moderate, but it's something to be aware of and think about if you're going through some of these type of symptoms. So just as a primary here, what are mast cells? Well, they're a type of immune cell, and they generally patrol connective tissues and neurological tissues, including the brain, throughout the body. And they are traditionally thought to be involved in mediating allergic responses. And throughout history and evolution, they've played a critical role in protecting from worms or helminths, as we call them, and from parasite infections in particular. So when a mast cell gets excited or activated, it tends to release a collection of inflammatory chemicals that we call cytokines. And the most famous of those is histamine, as well as leukotrienes, but there are many other ones as well, as you can see in the very small image to the right there. Activated mast cells not only create local tissue inflammation, but they may also send distress signals through the nervous system and the immune system to other areas of the body, and can alert other mast cells to activate in other tissues as well. So what are some of the symptoms of mast cells releasing local tissue inflammation and getting everything excited? Well, the most concerning one would be anaphylaxis. So that's a full-on reaction where you could stop breathing and lose your blood pressure as a result of a high response to an allergen. But more commonly, we see somewhat milder symptoms, things like flushing of the face, of the neck and the chest, lots of itching, and that can be with a rash or without. And what's interesting about that is it tends to kind of come and go over the course of a few hours and then be gone. A lot of rashes won't just come and go over a few hours and then be gone, or even minutes and then be gone. Hives are part of that as well, but they need not always be hive reactions that you see on the skin. Angioedema is a type of soft tissue swelling that we generally refer to in the oropharyngeal area, the mouth, the throat, the nose, and the lips. And so if a lip becomes swollen, or the soft palate becomes swollen, or the tongue becomes swollen, that can be part of an angioedema response. Itching in the nasal passages, congestion, or what we call rhinorrhea or runny nose. It can give asthma-like symptoms, including wheezing, shortness of breath, chest tightness, like an elephant sitting on your chest, or difficulty catching your breath or taking a deep breath. There can be itching and swelling in the throat and esophagus. Interestingly, we talked about mast cells having a role in the neurological system, and they can be a trigger for headache, including migraines, but they can also worsen other cognitive functions and lead to brain fog, anxiety, depression, and just dysfunction of attention, concentration, and focus as well. They play a role in the digestive system and can lead to diarrhea, significant nausea or vomiting. They can lead to abdominal pain, bloating, what we call gastroesophageal reflux disease, or heartburn, as it might be colloquially known. They can be involved in bone and muscle pain, and issues with bone health, like osteoporosis or osteopenia. They can be associated with lightheadedness, syncope, which is fainting, and that may be through some of the dilation of blood vessels on top of an underlying orthostatic intolerance that we see that. Can be associated with a rapid heart rate, palpitations, chest pressure, pain, low blood pressures, among many other symptoms. So mast cells are supposed to be activated in the presence of a type of antibodies known as IgE antibodies. And there are several other immune system triggers as well that activate them to have an allergic response if a parasite or a worm is present. However, in mast cell disorders, these mast cells seem to become activated by nearly any exposure to a foreign substance. And that can be completely independent of a traditional IgE or immune system trigger. And the reasons for this are somewhat unclear. We're learning more about it, but there's not always a predictable rhyme or reason to it. And you can even have a reaction to something one day and then not have a reaction to that very same thing the next. Symptoms can and sometimes do decrease in frequency or severity with pharmacological or drug therapies. And that includes classes of medicines called antihistamines, anti-leukotrienes, and then drugs that we use for stabilization of mast cells before they can become activated in the first place. And I would encourage everybody who thinks they might be experiencing some of these symptoms to consider a low histamine diet. This is something you can Google and find more information about. It is a very strict and hard to be consistent with diet for sure. But among people that stick to it, even if for a short time, they do notice a decrease in their mast cell related symptoms. And mast cell activation is not unlike small fiber neuropathy, probably worse. It's really hard to diagnose definitively because the sensitivity of our tests is just pretty low. And so a lot of times, the way we diagnose it is to say, okay, we have a high suspicion in the setting of these symptoms and in the setting of a post-viral illness that has continued for 6 months. And by the way, we tried either an antihistamine therapy or a low histamine diet, and there was a positive symptom response. And usually that's enough for a clinician to act on and continue to help you work towards better management of these symptoms. So we talked about the mast cell triggers being just about anything in the environment, but just a quick list of things that have been recorded. Temperature changes can induce mast cells. So it's like you're allergic to heat or cold or certain weather patterns. Stress, and that can be emotional stress, physical stress, such as pain from maybe an underlying small fiber neuropathy, or again, weather changes, pollution, pollen, pet dander. That's my Bernese mountain dog right there that you can see. Exercise can trigger mast cell activation. Fatigue in general can trigger mast cell activation. So clearly this is a loop of things that continue to make each other worse. Food, beverages, alcohol, and drugs. And I don't mean illicit drugs so much as actual things that are prescribed or that are even supplements. I had a person tell me the other day she wanted to be healthy, so she started juicing. And I'm not sure what was in her juice, but whatever it was, it definitely triggered mast cell symptoms. Natural odors, chemical odors, perfumes, and scents. I once had a patient come into my office and say, your body odor is causing me to break out right now. I thought I was wearing deodorant that day, but apparently not enough. Venoms from bees, wasps, spiders, fire ants, jellyfish, snakes, flies, mosquitoes, fleas. Infections themselves, if you were to catch another infection like a common cold while you have this going on, that can make your mast cell worse. There can be worsening from mechanical irritation, friction, or vibration. There's something that doctors call dermatographism. In other words, we can write on your skin, and I could just take the edge of a pen and scrape a letter into someone's skin very lightly. And then you can see 30 seconds later that appears in sort of a red, swollen, irritated area. And even the sun or sunlight can be a trigger for mast cell activation. And in fact, in my former field of rheumatology, people would mistake mast cell rashes and reactions for a lupus reaction to sunlight.
Thank you both. That was really, really comprehensive and inclusive. Couple questions here. Going back to orthostatic intolerance, are there things that viewers can go back and bring to their physician to help them assess for OI?
I think that probably writing down your symptoms, learning about them, putting these symptoms down on paper, and then many people have talked the staff in their doctor's offices into doing the 10-minute Nasaline test. This is you may have heard about this. This is, we really call it this so that it follows a standard procedure. Doctors have done all kinds of orthostatic testing, but they tend to be in a hurry. Sometimes they have you sit and stand, and sometimes they just do it for 2 minutes. So the Nasaline test helps guide them to do a period of rest, lying down, collecting a blood pressure and heart rate and then collecting it for 10 minutes while you're standing. If you can't get your doctors to take the time to do it in clinic, get someone who can take a blood pressure or an automatic blood pressure cuff and a pulse oximeter, and you can do this test at home. Just make sure that there are people around and that you stop the test if you're going to faint. Don't proceed and keep going with the test and end up falling over and hitting your head or something. So everybody needs to be paying attention. But writing this down and taking it into your doctor can be very helpful to assess orthostatic intolerance. I do want to say, though, you can have quite a bit of orthostatic intolerance and not have a rapid heart rate fast enough to call POTS. You can also have orthostatic intolerance and not drop your blood pressure enough to call orthostatic hypotension. So if the test you do doesn't fall into one of those types of orthostatic intolerance, you can still follow the general guidelines of treating it with fluids and sodium and compression and putting your feet up.
And then I did just want to bring forward, Dr. Yellman helped create 2 orthostatic intolerance videos with me last year. Part 1, and these are really geared towards medical professionals. So it's great to give this to your physician to kind of help explain and put into words what you're feeling. But part 1 is more understanding what orthostatic intolerance is and how to assess for it. And part 2 gets more into the intervention piece. And again, it's a lot of the words are, doctor talk. So it's good to be able to provide this to them and speak their language.
And they're only 6 minutes long.
Yeah.
Each one.
And they're animated. We try to do our best. Question here, can mast cell activation go into remission? Can making a healthy gut biome decrease mast cell activation better?
So remission is something that we would love to achieve. I think it depends what environment we're talking about mast cell activation in. So when I see it in chronic ME/CFS, I would say that we can often control most of the symptoms with aggressive therapies directed at it. Not always. Sometimes we get stumped with it and it's smarter than we are. But many times we can get those symptoms under control. However, if someone were to go off of some of the medications or to stop a low histamine diet that's helping, it would probably come back. So if you count that as remission, then I would say yes. However, in our post-COVID community, it's certainly possible that if we are able to achieve remission with your other symptoms, that mast cell activation may indeed come along with that. So we don't really know the answer to that. But we are hoping that early intervention, recognizing these symptoms and managing these symptoms very early on, will actually help them not become ingrained as a chronic process. Where is that threshold or barrier for people? We have no idea. although I think many of us who've worked in this field for a long time have seen individualized cases where people catch things early enough and have good interventions early enough that they tend to feel significantly better and close to what we would call remission.
I'll just add that I'm not sure we totally understand why mast cell activation occurs. But we know that a lot of times when there's a chronic inflammatory process going on in the body, it sort of, gets your immune system a little bit activated and makes those mast cells kind of on alert. So the thinking is, in my opinion, with something like a post-viral syndrome, that, if you have active mast cell activation, it sort of creates a vicious circle, right? Because the mast cells release and it makes more inflammation, and the inflammation from the virus, makes more mast cell. So every part of the illness that we can wrap our mind around and try to calm down and intervene with gives us a better chance of all of the inflammatory symptoms and the neurologic symptoms and everything to gradually calm down. So that's sort of the process. It may seem like we're being very simplistic when we say, slow down, get restorative sleep, don't let your orthostatic intolerance, go untreated, and don't let the mast cell go untreated. But, all these little interventions can create a better overall state of health, and particularly if you're not constantly pushing into post-exertional malaise, because almost every symptom of illness can flare when you've pushed too hard into post-exertional malaise.
How do you assess for mast cell activation? And then what are some treatments that don't cause drowsiness? Going along the line of antihistamines, are there other options where you can function during the daytime?
So I'll talk briefly about some of the meds, and I'm going to let Dr. Yellman add. Mast cell activation is something that doctors can understand and learn about. And if the primary care doctors don't, then an allergy immunologist can. This is a little bit of a new idea, but I think it's getting more and more understood in the allergy and immunology community. So getting in to see someone who's a specialist is probably the first step. And the tests are basically looking at blood and urine for the evidence of the release of histamine and histamine breakdown products and some of the other cytokines. So sometimes it's a little hard to pick up because the symptoms, maybe flare and then they'll go away. It'll be in your blood, then it'll go away. So, sometimes you have to work at it and do it when you're symptomatic. You also might have a harder time getting a positive test if you're on treatment, because the treatment is designed to block release of these of histamine and cytokines. So there are quite a few antihistamines. We call them non-sedating antihistamines. Basically, they're Zyrtec, Allegra, and Claritin, and drugs that generic versions of those and other iterations. And if they can be sedating to some people. Most people tolerate them pretty well. And you can go among them to see if you can find one that you tolerate better.
I would add to that that the drug Pepcid or famotidine, which is a stomach acid blocker at its core, at least when it was designed, is also a histamine blocker, and it blocks a different histamine receptor than those other drugs that Dr. Bateman just mentioned. It's a histamine 2 blocker, and it can play a role specifically if you're having gut symptoms from mast cell activation. Go ahead.
No, you'll go ahead. I thought you were done.
As far as making the diagnosis, I very much am an old school physician and rely on a history and physical and suspicion rather than only blood tests. And, when people meet the criteria and have a context that makes a lot of sense for mast cell, knowing that these tests that Dr. Bateman referred to can be so non-sensitive. I mean, we can have someone who has a rip-roaring mast cell activation and the tests can still come back negative because we timed them at the wrong time, because the samples degrade quickly or weren't handled right by the lab. I tend to think of interventions like antihistamines and other drugs that help with this as diagnostic interventions to start. And if you respond to them, then we continue along a path of therapy and maybe more aggressive therapy. In addition to Antihistamines, there are anti-leukotriene drugs. The most famous one of those is Singulair, which is used for asthma. It's also called Montelukast. And then there are drugs that are designed to stabilize mast cells themselves. So instead of blocking the inflammation that's released from the mast cells, but still allowing the mast cell to send a distress signal to other mast cells, we can sometimes freeze those mast cells in stasis before they get activated. So we call those mast cell stabilizers. And for some people, those are also very helpful.
I'll add that, you can do this test yourself a little bit. These medications, many of them are available over the counter and in generic. And I usually start with a combination of H1 and H2 blockade. So H1 is an antihistamine, and H2 is the famotidine that Dr. Yellman just mentioned. And a little rule of thumb is you can take it about twice the dose that it says on the over-the-counter dosing. So if the Zyrtec says take 10 milligrams once a day, you can take 10 milligrams twice a day. And if the famotidine says 10 or 20 milligrams once a day, you can take it twice a day as a diagnostic test to see if doing that blockade changes your symptoms. And that's another piece of history you can take in to your doctor to talk about whether you have mast cell activation.
We also touched on dermatographism a few minutes ago, but if you can take a pen like I have here and just make a light scratch on your skin and write a letter, and then that letter appears 30 seconds later and stays for another 5 minutes, you'll get their attention.
He means a letter of the alphabet, not a whole letter.
Maybe
a whole long letter. Dear doctor.
Your favorite symbol, a star or something.
I'm just joking you.
One more question for you guys, and I think that this is a big one, and all of the resources that these physicians have talked about today, I will include in that recap, and you can also find them on our website. They're broken down for physicians and then patients, as well as support resources. But my last question for you guys is, how do you get your doctor and loved ones to believe you?
That's a complicated question.
Go to our website.
Yeah, go to our website. It's helpful. That's one of the reasons we try to tease apart these comorbid conditions and different aspects of illness, because for many of them, you can get a diagnostic test if they're just not commonly done, but doctors can do them. And I'll tell you an example. I have a patient, not a long COVID patient, but an ME/CFS patient who's been so sick. He's had such severe everything, pain, orthostatic intolerance. He can barely function, and nobody but his family believes him. And he was not allowed any kind of disability insurance, and he's so they get stuck. He can't work, and he can't get health insurance, and he doesn't qualify for Medicaid because there's no proof. So he finally at the University of Utah, in the hands of the really good autonomic neurologist there, not only had abnormal tilt table testing, which is the more formal version of what we do with the lean test. Sorry, that's my bird clock. But he also finally had a skin biopsy, and the skin biopsy showed that he had small fiber neuropathy. So these little small successes can help build that case so that people understand what you're going through.
Dr. Bateman, what do you recommend for people when they're trying to explain post-exertional malaise and how they can't go to work that day or how they can't push through an exercise on those days? What have you found most helpful over your career for them explaining that to their family members or their physicians?
Yeah, I think it's super important for you to understand it first. And because you can't explain it to someone else unless you understand it yourself. And it's really hard to understand post-exertional malaise at first, because you don't always feel sick while you're doing the activity, right? Sometimes there's a delayed response. It can be a day or 2 days, and once in a while, even 3 days before the symptoms come roaring back from doing the activity. And it might be a combination of activities, but the more observant you are, the better you get at assessing what you do and how it affects you. Then you can point it out to other people. And I know I have lots of people whose spouse or children say, "What are you doing? You should stop by now. You're going to get post-exertional malaise." And so, if first you need to understand it, then you need to carefully help people observe it in you, right? And try to understand it. When patients are, if a patient is in my clinic, I invite them to bring someone in their family to their visit, so they can hear it from me and not just from the patient. Sometimes that helps, and is challenge. People are people, and they're busy, and they want you to be well, and they can be impatient. And we know from many, many years with ME/CFS that you can look pretty normal on the outside and still be very impaired and very ill, be dealing with pain and orthostatic intolerance and cognitive dysfunction.
I would also go so far as to add, sometimes family members know when you've pushed beyond your energy envelope before you do. Your posture starts to slump, your eyes look a little heavy, and you might just be trudging along and they say, Mom, Dad, spouse, this is, you look like you're fading really quick. Let's take a break. Let's go relax. And then when you do so, and then you find that maybe the next day wasn't as painful as you might have been experiencing prior to that, that can be really powerful for all involved as well.
I want to also emphasize, if I can, that you should be hopeful that over a period of time, your symptoms are going to improve. We have no reason to think in long COVID right now that your symptoms are never going away. So we don't know. We don't know how to predict that, but you should be as optimistic as possible and take really good care of yourself so that the very best outcomes can occur. Thank you.